morning. My presentation concerns whether we have good reasons for the division of the biomedical world that we make into research and practice, while requiring ethical oversight systems only for research. First, I will discuss how and why required ethics review committees emerged in the 1970s with a burdensome network of rules and oversight systems for clinical research, while creating nothing truly comparable for clinical medicine. Second, I will look at why we need to change the current system, that is to say, the current oversight systems that we have, to incorporate clinical medicine, not merely research. Third, I will look ahead to the way the healthcare systems that we have known ideally should be reconstructed to integrate healthcare with research, information feeding back to the healthcare systems, while also creating better systems of ethics. Much of what I have to say is dependent on a project team with whom I've been working for several years, mostly at Johns Hopkins. Team members include Ruth Faden, Nancy Cass, Sean Tunis, Peter Pronovost, and Stephen Goodman. I owe them a great deal for the ideas in this talk. I start with a key historical question, at least key for me. When did we first come to appreciate that there was a profoundly important need for a system of human research protections? I believe that no truly meaningful and widely accepted human research protection systems appeared prior to the late 1960s to early 1970s. More precisely, the prime startup years were 1971 to 74. Although the Nuremberg Code has often been proclaimed the earliest influential code, it is a poor choice in my view for the beginning of organized protections. The Nuremberg Code was drawn up by Americans specifically for the trials of German physicians. For 2 decades after it was issued, the code was either ignored or explicitly rejected in every country known to me, including the United States, East Germany, and West Germany. For our part in the United States, we never took Nuremberg seriously, even though an American military court had declared it in effect the moral law of research ethics. We now know that during the years 1946 to 1966, there was an astonishing degree of moral ignorance and insensitivity in many institutions of biomedical research, despite what had happened and was well known to have happened in Germany. It's also well known that the United States government and some of this country's premier universities and institutions were, at the same time of the Nuremberg trials, engaged in paradigm cases of research scandals. These now infamous scandals should not cause us to lose sight of how bad the situation had become in various parts of the routine, not the extraordinary, but the routine affairs of biomedical research. This was the thesis defended in the famous 1966 article by Henry Beecher, who showed how embedded moral misconduct was in clinical research. Beecher implicitly showed that we had learned nothing from Nuremberg and that we basically had no embedded or codified system of research ethics. We soon thereafter came to the conclusion that research must be systematically regulated. The most critical period is 1971 to 1974, because it was here that the period of laxity and scandal begins to turn around and the pace of protections then escalate dramatically. The sweeping policy changes in the 1970s at the federal level in the United States required most human research to be overseen by a system that included ethics peer review prior to conducting research, an adequate consent process, special attention to vulnerable subjects, and the like. This system of impartial third-party oversight was not imposed on clinical practice, only on research. There is one common belief about this history that I want to challenge. It has often been reported that the United States Senate hearings on experimentation in 1973 and the subsequent deliberation of the National Commission for the Protection of Human Subjects between 1974 and 1978 presumed that only research needs regulation, not clinical practice. This is an undue simplification, in truth, a falsification of the history. The Senate hearings on human experimentation, chaired by Senator Edward Kennedy, had a significant focus on what might be called the territory between research and practice, but called at the time practice, a territory at the time also commonly referred to as innovative practice. Senator Kennedy's concern, as well as many of those who testified before him, was that vast areas of medical practice escaped ethical scrutiny because the innovators presented themselves as engaged merely in the routine practice of medicine. Kennedy was concerned, and so was the National Commission, that the most dangerous area of medicine might be clinical medicine of this sort, not organized research medicine. But for political reasons, overtly political reasons, but unavoidable ones, this thesis could not be pursued either by Senator Kennedy in the Senate or by the National Commission. So it dropped from the scene, well, not from the scene of all academic discussion, but from the political scene. This political situation was the background for a public law that created the National Commission with a special mandate to establish the boundaries between research and practice. The public law seemed to presume that there is a close distinction and a clear distinction between research and practice. One simply has to figure out how to determine what the boundaries are between the two. However, legislators did not figure out how to draw that line, nor, in my view, has anyone else. The Commission settled for a document, the Belmont Report, that laid down the conditions that must be satisfied for an activity to be research, knowing that its criteria do not even begin to address the problem of unapproved innovative practice. In truth, that problem was put on hold and shelved, not resolved, and in my view, it has never been resolved to this day. So much then for the historical background and theses. Now I want to use this history to turn more to ethics and public policy. The dominant paradigm in research ethics of oversight systems has rested on a segregation model that splits up clinical medicine and clinical research into two very separate domains. This model, so far as bioethics is concerned, was created by the National Commission between 1975 and 1978 in its deliberations. It did not pre-exist. This commission created two criteria in the model that have ever since been widely used to distinguish research from practice. These two defining conceptual features, supposedly distinguishing research from practice, are first, research designed to develop generalizable knowledge, where generalizable knowledge is the key conditions. Practice, by contrast, is designed solely to help the patient at hand. Second, research requires systematic investigation and collection of data. Practice, however, has no systematic investigation and data collection. I challenge the clarity and acceptability of these conditions as a way of distinguishing research from practice, and I challenge the need for the distinction in our institutions in the way in which it is pervasive today, and I believe the problem is going to become more acute in upcoming years. Consider the first criterion of generalizable knowledge. This notion has never been carefully defined or analyzed in government regulations or in scholarship, and nothing clearly identifies it as outside the bounds of clinical practice. In my view, generalizable knowledge is no longer serviceable as the primary criterion to differentiate clinical research and clinical practice, and to tell us what should be regulated or have an oversight system. I expect our system of the delivery of healthcare to increasingly become an environment in which clinical centers are directly engaged in research and their clinical services are constantly being improved by the data received. Here, data assimilation and use for patients will become integral to the best practice of medicine, not merely something done by remote research. Accordingly, I believe a better model than the current segregation model is an integrated learning healthcare center designed to simultaneously deliver the care that patients need while capturing the experience of clinical practice in systematic ways that produce what we think of as generalizable information in order to directly improve care for both present and future patients. In an integrated healthcare center, the production of generalizable knowledge will simply be part of the practice of medicine. The segregation model, distinguishing research from practice, will, I believe, increasingly become obsolete. If this hypothesis is justified, it is time, I believe, to consider whether we should restructure our current system using an integration model. And this is particularly true, I believe, for bioethics. A U.S. Institute of Medicine report seems correct in stating that we are now, and I quote, drawing research closer to clinical practice by building knowledge development and application into each stage of the healthcare delivery process. In this conception, measurements taken in the course of clinical care are recorded with the intent that these measurements be used both to modify patient care and to feed information to ongoing studies in a constant loop. This system is designed to simultaneously treat patients at hand and facilitate new knowledge. As such systems are developed, and we're certainly only in the very primitive stages of having such systems, research and treatment will become increasingly integrated, not segregated. Growing numbers of activities in healthcare institutions already cannot comfortably be classified as either research or therapy, or the one excluding the other. For example, participating in a clinical trial may be regarded by a woman with melanoma as her best treatment option, even if the specific treatment she receives is determined by random assignment. As a second example, quality improvement in patient safety research designed to evaluate whether various kinds of reminders of drug interactions might reduce medication errors does not alter the patient's experience of clinical care, stands to improve clinical outcomes for future patients, and may improve outcomes for patients who are receiving the care while this intervention is being tested. Since the 1970s, the view has been deeply ingrained that research with patients is riskier and less likely to produce net clinical benefit than is clinical practice. This view has been an important part of the rationale for regulating and reviewing research, but not practice. But is research, in fact, riskier than practice? There is growing recognition that many therapies, tests, and interventions used regularly in clinical practice are of unproven value, and many may be harmful. The Institute of Medicine estimates that more than half of treatments in current use in medical practice lack adequate evidence of effectiveness, and many surgical and diagnostic procedures disseminate into practice with little or no prior scientific study. Mounting evidence indicates that patients in ordinary clinical care are often at risk of receiving suboptimal outcomes and of being harmed, however inadvertently, as a consequence of inadequate evidence use of unproven practices, and biases in clinical judgment that might be corrected. Substantial evidence now points to the frequency and severity of the clinical harms patients experience as a consequence of medical errors and lack of supervision in healthcare. The exact number of patients harmed from healthcare is unknown. There are no reliable overall statistics. But we know that approximately 100,000 people die annually in the United States from healthcare-acquired infections. Approximately 100,000 die from healthcare-related venothromboembolism, and many thousands die from care that results from teamwork failures, medication errors, falls that occur in healthcare institutions, diagnostic errors, and medical device errors. We do not know how much of this harm can be avoided, but where focused, targeted improvement efforts have been tried, most of the harms have found to be preventable. I'm not denying, of course, that research studies expose patients to risks of harm. Of course they do. The point is that standard care does too. There is simply no good evidence to support the long-standing empirical assumption creating the split segregated system that I mentioned earlier, to support the long-standing view here that research studies as a class are more likely than clinical practice to run counter to the medical best interests of patients. I turn finally to a profoundly important issue about ethical oversight and committee review. Unlike the research context, third-party oversight is generally not required to ensure ethical use of interventions of unproven clinical benefit and unknown risk in clinical practice, or to systematically avoid diagnostic and other forms of errors. There is little, if any, prospective moral scrutiny of practice comparable to the scrutiny of research. And though practice contexts can put patients at unjustifiable and avoidable harm. For example, patients may have surgery at the hands of surgeons or teams who rarely perform such an operation, despite empirical evidence that low-volume hospitals have worse outcomes than high-volume hospitals. In important respects, these patients are experimental subjects, not merely patients, often without their knowledge or consent. Medical error and other clinical risks, therefore, need to be supervised and monitored, much as they are in research. Protection from harm is the underlying moral problem and should be our premier concern. It should not matter whether the harm occurs from what we categorize as research or categorize as practice. It has been a mistake from the very start that we require review only of research. This kind of underprotection of patients in practice is one side of the problem, and overprotection of patient subjects is another side that I really can't get into. But requiring that all activities that are designed to produce generalizable knowledge and that collect data systematically must undergo prior review by an ethics review committee, even when patients' clinical care is in no respect changed, is a misplaced moral criterion of what needs review. Requiring only what is classified as research to undergo the burdens and costs of extensive oversight creates disincentives to rigorous learning. It's costly and regulated, and thereby increases the likelihood that interventions will continue to be introduced into clinical practice and healthcare systems in the absence of scientific efforts to evaluate their effects. That's obviously a disaster of a system if that's the system that we are perpetuating. I conclude. The idea of organizing healthcare institutions as a system in which research and practice are seamlessly integrated did not exist when regulatory bodies governing research involving human subjects were initially developed. Our now well-established system has served us really commendably well in certain respects, especially in overcoming the scandals that I mentioned earlier. But we need today to identify more efficiently which interventions work, how errors can be reduced, and when interventions or tests should be administered or avoided for groups of patients. It is time to reassess our empirical assumptions about ethics review, what needs ethics review models, and the like, with the goal of coming to a more balanced understanding of what matters morally, which is the same in both in research and practice, namely protection from harm. Thank you very much.